Reproductive embryology, the placenta, and amniotic fluid. All right, so the placenta is going to be made up of two components, the fetal component and the maternal component. The maternal component is going to be known as the decidua basalis, okay? Essentially the basement membrane that protects the mother from the fetal component, all right? And we're going to see pathologies associated with this when we scrape off the maternal component, like the decidua basalis, but we're not going to touch on that right now. What you need to know is the fetal component. The fetal component is made up of two layers, the cytotrophoblast, and the cytotrophoblast is just like creates cells. It's like our stem cells. No one really cares. And then the syncytotrophoblast. This is the outer layer. This is what touches the maternal component, the decidua basalis. And it synthesizes and secretes hormones, specifically beta-HCG, within the maternal bloodstream, okay? And it lacks MHC1 expression because we don't want the mother's immune system to attack our syncytiotrophoblasts, all right? So what you have to know is that the syncytiotrophoblasts, it synthesizes and secretes HCG. That's the highest yield thing. Now, the placenta we know is the primary site of nutrient and gas exchange between the mother and fetus. And so that's just like the first thing. But the fetal blood and the maternal blood never actually mix. It's just via diffusion where we can change these nutrients and gases between the circulatory systems, okay? Next is the amniotic fluid, all right? The amniotic fluid we talked about multiple times, but it's derived from the fetal urine mainly, okay? And the way that we clear it is by the fetus swallowing it, okay? So there's two types of pathologies associated with amniotic fluid. You could have polyhydramnios, which is too much amniotic fluid, or oligohydramnios, which is too little amniotic fluid. Now, polyhydramnios, the question is, what might cause this? Well, we can't clear it as well, so that means that there's going to be decreased fetal swallowing because the way that we clear amniotic fluid is via fetal swallowing. So if we have decreased fetal swallowing, then we have an increased risk of polyhydramnios, too much amniotic fluid. Or if we have increased urine output. Increased urine output isn't really very commonly tested. They like to talk about decreased fetal swallowing. Now the question is, what can cause decreased fetal swallowing? Well, if there's esophageal or duodenal atresia, then that can lead to decreased fetal swallowing. Or if there's anencephaly, there's no brain. That means there's no swallowing center. That means the fetus can't swallow and you get polyhydramnios. Although that might sound weird, but that's a question that they like to ask, okay? And the way that the mother will present is that she will have a uterine size that's larger than gestational age. So if they say like the fundal height is like 22, well, the fundal height should be even or equal to the amount of gestational age or gestational weeks that the baby's at, so it should be 22 weeks. But if the mother's like 16 weeks and the fundal height's 22 centimeters, right? That means that we have a uterine size that's larger than gestational age, pointing towards polyhydramnios. And don't forget that anencephaly as being a cause of decreased fetal swallowing because we don't have that swallow center. All right. Next is oligohydramnios. That's too little amniotic fluid. Once again, that's associated with placental insufficiency, but specifically it's associated with bilateral renal agenesis. There's a problem with the fetal kidneys. So we can't urinate. And so that means we can't produce amniotic fluid. All right. That will lead to an increased risk for Potter sequence, right? So profound oligohydramnios can cause the Potter sequence that we'll see. All right. Those are the two most important things for amniotic fluid: polyhydramnios, oligohydramnios, and what can cause them. Next is going to be twinning. Twinning is relatively lower yield, so I'm just going to add it to the end of this. And all you have to know about this is that you can have two types of twins. This is dizygotic twins, which is fraternal twins, or monozygotic twins, which is identical twins. Now, dizygotic twins are just essentially two babies that are being born at the same time. So if you have a brother or sister that's essentially like 3 years older than you or like 4 years younger than you, it doesn't matter. They're not born at the same time as you. It is the same as having fraternal twins, okay? You have completely different DNA makeup. It's everything about you is different because it's two different eggs, all right? So dizygotic fraternal twins arises from two separate eggs, all right? And so they have completely separate, two separate amniotic sacs, all right? Two separate placentas, right? Separate fertilization by two different sperm, right? Everything is different. Now, for monozygotic identical twins, okay, they are the exact same person, essentially, coming from their DNA. They have the exact same DNA, all right? And so that is from one fertilized egg, meaning one egg and one sperm, but it splits. And the time that it splits will essentially define what's going on with our amniotic and chorion, our amnion and our chorion, all right? So what's the amnion, what's the chorion? Well, the amnion is just the amniotic fluid sac, okay? And it can be shared, meaning that the twins are in the same amniotic fluid sac, in the same amnion, it's shared. Or they could have separate amniotic sacs, separate amnions. They can also have the shared chorion, which is just a shared placenta. Or they can have separate placentas, separate chorions. All right, and that all depends on when the split occurs. So for monozygotic identical twins, if the split occurs between days 0 and 4, you're going to have separate everything because you split so early, they're going to be essentially completely separate. All right, so they'll have separate chorion, separate amnion. And they call those di-di twins. All right, and by the way, dizygotic twins, fraternal twins, are always di-di. right? Makes sense. If the splitting occurs later from days 4 to 8, then they have a shared chorion, okay? But they still have a separate amnion, and that's known as modi. If the splitting occurs later on, 8 to 12 days later, they'll have a shared chorion and a shared amnion. And if the splitting occurs after day 12, then they'll have a shared body. Shared chorion, shared amnion, and shared body. And remember, chorion is just placenta, amnion is just the amniotic sac, and obviously the body's going to be the body. Okay? Now, that's all for placenta, amniotic fluid, and twinning. If you have questions on it, let me know, but they're relatively lower yield.